Breathe again. What? I didn't see it. I was it. I'm enjoying it. Probably mostly you. Mostly, the other cities, Gisa, Barfara, Borama. Borama is perfect. But the wizard is same as the 4 minute distance, I think. It's calm, quiet. Not really easy kills. But to you. And no violence. Oh, yeah, it's like you don't see violence. Just cars. You see. In here. I need to. And back. It's far from here. It is a bit far. Like around 2 hours, 1%. No, oh, I know. Okay, before we last course we line sorry. Then after the source today second lecture since end of the so even you are in Zoom today. Yeah, so he's good. And then he just down starting then. You yeah. Nice. Can you Claro. انت مرتها
Ah,
الحمد لله.
Halo, Assalamualaikum. Facebook lah ya? Si fiican kolley daantada aan arkaya daantada.
Assalamualaikum. Subax wanaagsan. Subax wanaagsan taaban. Magnifica. Subax wanaagsan. And كنت بسولو إني معني كيس حاجة وكان كذا لبع شوية كنا بقوم من سوق على كل يوم سوق فرقني كلينيكال كرام أدوينا أو أي ما يعرفوا أن كوسوق أنا أنا هو سبب يسمى لو تشيل صور في واحد كان قاعدة 10 هي experience escuchar o ay escuché bien speakers aduana o waxay waqtigooga iyo cilmigooga iyo experience-kooga waxa laga yaabaa inta aynu barano iyagii qabtaan inuu isku mid yahay laakiinse siday u barteen iyo experience-kooda kuma kasta waa different sidoo kaleba different marka laga yaabaa iyaga laftooda inay experience-keeda wax ka ogaanayeen waxay ka baraneen maanta waxaynu daafarayn doonaa beeshan iyo waan kasoo wareegaynaa qolkii bal dibadii kusoo baxaynaa waxaad barataan sidee loo gaarsiiyaa bulshada laftigeeda sidee uga faaidaysataa iyo sidee loo sameeyaa kafaa'idaysiga ka badan inta aynu inaga iyo beeshanku isla wadaan waxaynu maanta daafarayn doonaa medical research sessionkiina koowaad medical research ku noqon doonaa oo ina siin doono Dr. Adnan. Intaynu sugayno inta setup kala dhamaynayo yaa haya reflection labada cisho hore si yaa reflection bixin karaya laba cisho wuxuu faa'iiday aniga maxaa takeaways ahaa oo halkan kala waqti badan bay kama aragtay ka saacadood waqtigeena ka badan intaan halka joogno intaynu ka maqanahay marka labada cisho baliyaa kala shaqeeya inkaa baynu ka dhiganay mas-uuliyadeenu gudani waxaan yeelayaa nafqaalid oo qur-aan loogu furi doona
ma lay maqlayaa
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Thank you. And the second another to build a better healthcare systems, we must first build Trevor's research capacity. It's an honor to introduce our first speaker today, Dr. Adnan here, a physician scientist from Rochester, New York, in the University of Professor, New York. Dr. Hill will break down major research designs, its principles, and how to successfully integrate research into primary care systems in low and middle-income countries. Dr. Hill, welcome, and you can start your session.
Assalamu alaikum and all salamati. Thank you guys. And I'm very impressed that they are organized. For the most part, the goal is to discuss the idea of evidence, right? Now, I don't know if I'm going to just deliver the whole thing in English or probably add some Somali to the mix. Do you guys hear me? Can you confirm you hear me well?
You can be that.
See if you're on English. Okay. Okay, the main goal maanta waxa weeyaan inaan ka hadlo the process of evidence generation. So markaynu nidhaahno qof kuu imaado ee ku yidhaahdo wax aad ka shakido inuu xanuun A ama xanuun B qabo, how do you make a decision as to what kind of treatment or recommendation you want to make. And that process seems simple, but it seems like we're having many issues when it comes to how that's being practiced within the Somaliland context. So I just wanted to demystify that process. Abdul Hakim's requesting to record. Yes, approved. And the goal for me then is to, work with you guys. This is going to be a small session. It's only 40 minutes. We won't have a long time to discuss all of this, but I want you to take some specific messages from this so that when you are fully trained and you are out there practicing, you can actually at least have that voice in your mind to kind of seek more knowledge, right? Now, the Hippocratic oath says what? It says, and by the way, this is the list of things I'm going to go over during my presentation. What trustworthy evidence means, how do you combine evidence, expertise, and patient values, why evidence and ethics, how they evolve together, right? So, the evidence-based system that we have today is actually young. It's from the 1940s and onwards. And the ethics that we use now to both generate the evidence and practice with patients have also been formulated post World War II. And the question, and then the third element that I'm going to talk about is, well, how do we know when we say, bacteria causes disease, or smoking causes lung cancer, or we say, we make any of these claims, what are the processes that we have to go through to make those kind of claims, right? What are the thresholds of evidence that we have to meet to make those to meet those claims? And then I'll give an example case, which is how we have arrived at the mRNA vaccines that we used during the COVID, for COVID, and probably we won't get to 6. And then I would like to open this for discussion and to talk about exactly what we plan to do. Okay, so evidence-based medicine is a decision process. Okay, now I'll give you an example. I don't see you, but I'm assuming that many of you know what idiopathic intracranial hypertension is, right? So recently, someone showed up to the clinic. This person, a woman, and she has been suffering from idiopathic intracranial hypertension for a long time. She gets headaches. She has all of these, it really affects her quality of life a lot. And when she came to the physician said, there's a new way that we can try to pinpoint what causes this intracranial, this idiopathic intracranial hypertension, right? Usually the treatment is if the person is young and they have an acute case and you have problems where you have, your pressures are high, then you could maybe do, you can drain some of their CSF and such, right? Now, interventional radiology can now look inside the brain and find out whether there are some vessels inside the brain, especially the dural sinuses or some of these the venous system in the brain that has a stenosis, right? And in this person, they found that there was a stenosis in some place within her, bilateral stenosis. After they put dye in the brain, they could see some of these veins were kind of closed down. So they think that was causing her idiopathic intracranial hypertension, right? Now you would think we have the evidence. We now know potentially this is what's causing this problem in this person. But what I didn't tell you is this person, how old is this person? It turns out this person is 7 years old. And what's the context of this person's life? this person also lives in Somaliland instead of living somewhere, like in Europe or America where things are advanced. Now you ask yourself, okay, now we know this, what's the intervention that's being proposed? The intervention that's being proposed is to put a stent in these vessels, right? And anytime you put a stent in a vessel, all of a sudden you have to also give blood thinners, right? Warfarin, and you guys know, many of you are medical students, and some of you are, of course, practicing physicians. If you give someone a blood thinner, especially warfarin, any of this, then you have to continually monitor, their blood. The question is, are the resources available to do that kind of monitoring for a patient in their 70s? All of a sudden, the evidence is not easy to make a decision about, right? You see a stenosis, the intervention would be really good if you just apply, if you did the stent. You don't know exactly the benefits, but now all of a sudden you have all of these issues you have to deal with because the patient's context really matters, right? So, of course, evidence that, is generated, from systematic studies and data and all of that. That's what the evidence is. Now the physician judgment has to come into place and take into account what kind of patient preferences are there, the cultural context, and what else is available within their environment. After all of that had been considered and the patient was told, okay, when we put this stent, we have to have you come out, let's say to Ethiopia or somewhere else, and monitor your blood, and we don't really know if it's going to solve all your tinnitus and all the other problems, we can't really be sure. All of a sudden, the person made a decision that they do not want to go down that road of putting a stent, right? So all three things have to be taken into account to make a sound decision that is also important, that can help that patient moving forward. And sometimes doing nothing is the right decision, despite knowing what the evidence says. Okay, so this kind of approach to modern medicine has not always been part of practice, especially. May maqlaysaa? Maxaa tiri? Ma aragtaan miya? Yeah? Well, big screen baan ma ka dhigay be. It is a big screen. You cannot read me actually. It's too small. Ma arkaysaan. Okay, sorry guys. Laakiin I will go over it. Waana idin soo diraya haddii la hayo, okay? Okay. Ma arkaysaan. Si fiican idinma maqlayo waayo echo baa jira. There's somewhat of an echo. Should I continue? Ha, waan ku maqlayaa hadda.
Okay, sir. Mana maqlaysaa doctor?
Hadda si fiican waan ku maqlayaa. Ha.
Waa slides-kaaga unbad slide show ka dhigi lahayd. Waan arkaynaa kuu nageeriya.
Ha, okay. Ma waxaad arkaysaan
xagga sare use slide show.
Okay, hadda ka waran.
Hadda okay. Waad mahadsan tahay.
It's now better. Okay, good. So I was showing you my notes from before. Okay, good. Let me see how I can advance. Advance. Let me see. Good. Okay. Good. All right. We can continue then. Okay. So basically, what this was saying is evidence-based medicine is a decision process. And so the main things are you have to think about the evidence, of course, but evidence alone is not sufficient. You have to now think about physician judgment and experience. and that that has to come into place. And then the patient's context and values, what their interest and preferences, right? And we had a case study. Now, I actually forgot to say something, which is I want you guys, if you don't remember anything else I tell you today, wax kala haddaydan iga xasuusanin, waxaan ka hadlayo oo dhan hadday wax kala xasuusanin, waxa kaliya raba inaad xasuusataan waxa weeyaan evidence seeking, inaad qofku inuu isku dayo, qofka dhakhtarka ama qofka health professionalka inuu isku dayo mar kasta maskaxdiisa ay ku jirto evidence-ka aan waxaan samaynaya evidence-kan u isticmaalaya xaguu ka imanaya, ya xagaan ka keenay, saan u bartay, xagaan ku arkay, kow taasina inay caado u noqoto, inuu qofku caadaysto. Haddaydan caadaysanin practice-kiinu hadhowtoole wax badan baa ka dhinaanaya. And that's the one message I want you to take from this. And I'll give you an example. There was a child who had their first febrile seizure, right? They had a febrile seizure at 3 years old. And the mother is not a medical professional. She doesn't know what a seizure looks like, but she thinks there was a seizure. She goes to a doctor, I'm not going to say who it was, in Somaliland, and she tells him, hey, this thing happened, right? And then all of a sudden I get a text from one of my family members saying, hey, this child who's a family member of ours was prescribed valproate, right? That's a heavy duty anti-seizure, anti-epilepsy drug, right? At 3 years old. Now, clearly, if you had done any amount of evidence search and tried to look up the latest guidelines, you will easily discover that one, this is the first febrile seizure in a child. Two, you don't have really great enough evidence. And three, you should not be giving this as a first time drug at all. And you don't even give a drug for a first seizure in a child, right? At that age. And then, and there are many, right? And so I told them, don't give that person, the child, the medication. Another incident, very recently, a child has a lot of temper tantrums. He's 6 years old. Yeah, he's taken to someone who is supposed to be a psychiatrist. And after a few minutes of talking to the mother of the patient, the first drug that's given to them is risperidone, right? Risperidone is a very very heavy duty antipsychotic, antipsychosis drug, right? Causes one of its side effects is tardive dyskinesia. These drugs, these heavy duty drugs, can cause a lot of harm. Yeah. كلمة الدواء in Somali it only sounds, it has no, it sounds positive. But as we know, the first rule of medicine is do no harm, right? Do not harm a person. That means with medications, with treatments, with anything you are doing, there is a potential for harm, and you have to really think about that. And the only way you can think about it, and you can get to a resolution, is to understand the evidence base of why you're giving this drug and why not this other drug, or maybe you shouldn't do anything. So the main thing I'm telling you is that I want you to take away from this whole presentation is make sure you are evidence seeking as you go along. Always learn. There are very great resources. All of you should have access to up to date, right? You should be always asking yourself, why am I giving this drug? Or, should I give this drug? What is the patient interested in? Use common sense and wisdom, right? Okay, now, in the US and in the West, this did not come out of nowhere, right? Back in the day, practice used to be based on apprenticeship. There was a doctor who was a senior doctor who learned from another doctor who was, that taught them. if you see this, give this drug. If you see this, give this drug, right? But at some point, there was a discovery that authority, that someone just being senior to someone else is not enough to make a decision, right? Now, there was also a problem with in, location A, people using a specific kind of drug for hypertension, and then in another place using another drug. And these differences were completely not based on any evidence, right? And there was also a realization that once you had transparency, meaning transparency in your decision making, I should be easily able to figure out why that decision was made, right? I don't need to talk to that doctor. Any other doctor near you who understands the same context of this child should be able to say, yes, I understand. Maybe there's a little difference here, but risperidone would be the right move. There's no one here in the US that I will tell that story to that will find that reasonable. And that is because, and so evidence allows for us to have a transparent decision-making process. How the doctor arrived at that solution, right? And then sometimes things that have been done for many, many years actually cause a lot of harm to patients. So there was a drug that was biologically plausible, for example. They used to give these anti-arrhythmia drugs to patients after a heart attack, right? After a myocardial infarction. And it turns out when they did randomized clinical trials, this was a bad idea. Those patients who were getting this anti-arrhythmia drug, whose arrhythmia was being resolved, were dying more frequently than these other patients that were not getting the drug, right? So sometimes something that looks reasonable, if there's no evidence, can be very harmful to patients, right? And this is what we're talking about in these forums. Authority was not enough. These are the reasons why the West in general made the decision that the best way to practice medicine is to use evidence-based medicine. All right, so here this slide captures the sort of the timeline of evidence-based medicine, right? Very early, there were diet trials and all sorts of things, but then there's this scurvy trial. But the main thing is that I wanted you to take away from this is the evidence, the systematic generation of evidence is actually not that old, right? It started in 1946, right? And this idea of evidence-based medicine being now, what up to date is, which is what up to date is based on, and all the references that you guys read will be based on, is only from the 1990s. And luckily for us, for people in Somaliland and people in Africa, you can participate in that process now because it's not that old. People are still learning how to do this. You guys in medical school and those of you who are practicing and just out of medical school can actually join in this revolution and be part of it because your families, our families, we all have families in Somaliland, right? They need to benefit from this evidence-based system. And the only way they can do that is if you guys start practicing medicine that way and break the cycle of just using, of using basically your own ideas or whatever you saw with someone or something like that as the main way you practice medicine. Okay, now, but now there are also ethical codes, right? Whenever we're doing these medical trials, we have to always be aware of the ethics of research, right? Back in the day, they used to start experimenting on people without ever telling the patient, hey, this what's going on is research, right? There's a famous study called the Tuskegee syphilis trial in the US, where patients with syphilis were denied medicine, although the doctors knew their penicillin was available, and if they gave it to them, they will become better. These people developed tertiary syphilis. These were all black men in the US. And in the 1970s or 80s, sometime along that time, the discovery was made that these patients were lied to, were not told, where evidence was omitted, and these people now develop these horrible diseases and die eventually. There was also another study where thalidomide basically was prescribed to pregnant women without any testing, and about more than 10,000 children were born with birth defects, right? And there were many other actually types of trials. Okay, so the Tuskegee trial, that kind of practice, whenever there's a failure, the next thing to say is how can we prevent that from occurring again, right? So the Tuskegee trials led to the IRB protocols, right? In the review board. So the patient has to, if someone is going to be participating in research, it has to be voluntary. They have to be able to withdraw anytime. They cannot be coerced, meaning forced into doing something. All of these have to be part of it. And the person who is doing the research cannot be the person monitoring the ethics of the research. Someone else has to, right? Because there's a conflict of interest, and that other person can now say, okay, after reviewing what you have proposed, it meets all of these criteria, and you can carry out your research. And I'm talking about research where you're just collecting blood pressure of someone, right? Even that needs some sort of IRB approval. So whenever there's a failure, I want you to remember to think, okay, what are the ways that we can prevent this failure from occurring again? And so these failures from the 1960s and such led to a lot of the systems that we have that now prevent from people practicing research on patients without their consent. Ethical codes basically take these principles and they enforce standards, right? The core principles are respect for persons, beneficence, meaning you have to always think about the benefit accruing to the person, meaning you should not be doing them harm. If I'm studying a blood pressure problem, let's say hypertension in the US, in Somaliland, and I know there's a drug that works for people, and the person comes to me with a systolic of 180 and and a diastolic of 90, and I'm like, hey, I want to understand how blood pressure, uncontrolled blood pressure affects end organ disease in the long term, right? And now I'm not going to give them, the diuretics or lisinopril or any of these, anti-hypertensive drugs. That is unethical. You cannot do that kind of work, right? So that makes sense. So these codes, the core principles come from you have to respect the person's, desire, right? Autonomy. You have to do no harm, and you have to think about justice. And then the Nuremberg Code, the Declaration of Helsinki, and the Beaumont, codes. They standardize that process, so no one can do this kind of practice. Okay. Just to remind you, there's informed consent, right? You have to sign. You have to document all the things that happens during your research, and the patient has to consent to doing those things. And we're talking about the things that have been approved to do no harm to the person. They still have to sign saying, yes, I accept. And within that, it's voluntary, and anytime within any period within that research, they can withdraw. And then there has to be an IRB oversight. If there are children involved, or vulnerable populations. So vulnerable populations is this kind of work cannot be done on prisoners. Prisoners are basically captives of the state, and they cannot be part of research. I'm just giving you these so that if you start thinking about doing research, you can think about the ethics frameworks that you have to enforce to do it right. When these ethics fail, and the ethics are not just at the level of research, right? You can do more harm even after the research has been conducted. In the U.S., there have been a lot of deaths from overprescribing opioids. It was because of aggressive marketing. They basically promoted it as, it doesn't cause addiction. So there's a lot of marketing. There was a collusion between between the company and the doctors that were prescribing, and there was a conflict of interest. Ethics were ignored because doctors got paid more if they prescribed more. So what did they do? They gave more doses. They did all sorts of really terrible stuff, and that led to up to 68,000 deaths by 2020, and it was a big crisis in the U.S. And we're still dealing. Entire communities had been decimated by just these ethical lapses, right? Again, it's really important to repeat. Drugs, they're not always positive. They can cause harm. And if they're not prescribed within a specific limit, they can cause problems. All right. I think I'm going to run out of time. But anyway, so there are two things I want you to remember about how when we say something causes a disease, right? We say bacteria, tuberculous bacteria causes tuberculosis, TB. How do you know that evidence? Okay, how do we know that? That comes from what they call Koch's postulates. I want you, especially the medical students, I want you to write that down. I want you to read up on it. What is the way to think about how exposure to agent bacteria A causes disease Y, right? Thinking about that. Those Koch's postulates are a codified way to kind of systematically examine that causal evidence that A causes B. Haddaan dhagax kugu tuuro oo madaxa kaaga dhaco oo dhiig kaa imaado, that is a direct causal mechanism, right? I threw a rock, madaxu kaaga dhacay, laf baa ku jabtay, dhiig baa kaa yimid, right? Now, it's not in medicine, that's not always clear. So to pinpoint that, you need the Koch's postulates, and you can read up more on it, and I want you to write that down. Koch is the name, okay? Now, you could use the same causal mechanism process of thinking to interventions, right? How do we know that if I give you drug A, let's say I give you lisinopril, your blood pressure is going to go down by a specific amount of, millimeters of mercury. That also, this Koch's postulate process can be used also to get to that answer. Now, there are mechanisms like randomized controlled trials, and the kind of study you run is different than the idea of the causal mechanism. How do we know A causes B is a very important mechanism for you to kind of start thinking as a medical student, so that when you are a doctor and a patient comes to you and tells you something, you can remember to think in that way and change your mind in a persistent way. Okay, now there's also what they call the Hill's postulates, right? At the population level, so let's say, God forbid, there is salmonella, something in lettuce, right? Saladka waxaa salmonella ku jirta, okay? And a whole group of people are kind of falling ill, and then they show up to the emergency room. Or let's even not say that. Let's say there's a lot of smoking. People are smoking, and then all of a sudden, or you don't know what's causing it, but you see a lot of lung cancer in the clinic. The numbers go up. How can you determine what's causing problems at the level of the population, right? If something is happening at the level of the population, right? How can we determine? And those are called the Hill's postulates. Now, I don't have time to go over all of this right now, but I want you as medical students to go ahead and think about those two frameworks for understanding cause, how A causes B. Okay. Evidence there's a strength of evidence, right? The weakest kind of evidence is expert opinion. Yeah. Hebel baa igu yidhi is not really good evidence. It's good if you trust the person. Qof aad ku kalsoon tahay uu yahay oo aad magaranaysaa, you can go ahead and take it. But usually expert opinion, there's a lot of bias. Then there are case reports, right? You describe some unique cases, and from that you can generate hypotheses. And the highest level of evidence, you can do RCTs, what they call, right? Randomized controlled trials. So you say, okay, we're trying to test if lisinopril is better than, let's say we didn't have any hypertension drug for hypertension, and we're going to give thiazide, right? And there are people with high blood pressure and then people with no high blood pressure. One group in a blinded way, as the person running the trial, you don't know who, someone does the randomization, meaning the first person shows up in a random way, they're given thiazide, and then the second person shows up and they're not given any drug. And then from there, you do that random way and randomization, and the person giving the drug doesn't know who has what drugs what. They're just giving it, right? Ultimately, if you determine from that process, right, you have one person getting the drug, one person not getting the drug, and then you compare the two, and you see the person who's getting the drug now all of a sudden has improved, and the person not getting the drug has not improved. That kind of randomized control trial is the highest standard that you need to achieve to say this drug can be given for condition A or condition B or condition C, right? That's RCT. Now, if multiple studies from RCTs from many different places converge on the same evidence, then that's even higher. That's a higher threshold of evidence, meaning that's the best kind you can get to, right? But RCTs are the gold standard. Now, the process of reaching that level, ultimately, this is the kind of research, my area of research, most of my work in research is here in the level of the discovery and preclinical, right? Should I stop? Should I continue, or I heard a voice? Anyway, when am I done, by the way? Tell me when to stop. Huh? I'm so sorry. Waxa weeye echo baa jira marka si fiican kuma maqlayo markaad ii sheegayso. Ma 45 baan ku dhamaynaya mise 9 buu dhamaanaya?
Waxa ku haray 7 daqiiqo.
7 daqiiqo. Okay. I want to make sure that we have time for discussions. Anyway, there are 4 phases, discovery, a lot of research has to be done in the lab. It's done with animals, with mice, with all sorts of things. And then phase 1 and then phase 2, there's a testing of safety and dosing of that specific medicine, right? So you say what dose is reasonable to give for a condition, right? That's how you know to give 20 milligrams of furosemide or 40 milligrams or what the highest limit is. If you give someone, when you're getting to IV furosemide, that's what Dr. Humphrey does sometimes right? And you have really huge blood pressure problems, then you have to have a certain set of conditions available to a patient. So doing that dosing and testing of safety is also important. And then at the end, you get to the large trials where you have to take a large group of people and you try the medication, again, using the randomized control trials that we just talked about, one group gets the drug, another group doesn't get the drug, and then all of a sudden you can determine, over time, you determine how beneficial the drug is. And many, many drugs die at that phase 3 level. A lot of them die at phase 1 and 2, and many things do not stay within the discovery and preclinical area because they never result in evidence that can be used. Now, I'll give you a quick evidence, quick place where this happened, right? Messenger RNA, which is what we need to generate proteins in the cell, was discovered in 1961. The first time mRNA vaccines, the mRNA vaccines, the Pfizer and the Moderna, the stuff that people were given for COVID, the first injection was in 1990, but it was just to test, right? And when it was injected into a mouse, it worked. That was a good thing. But that caused a lot of inflammation and problems. And so we also discovered there was something wrong, and we had to test this whole thing out. Now, a lot of things had to happen, and it wasn't, right? From 1961 to 2018, that is when we got to the first approval of a drug that contains RNA as its main ingredient. I'm not going to go through all the research. Everything that happened before that, right? 60 years, whatever that is, that's a long time. Whatever happened in that time period, that was all preclinical research, right? It was this first stage here. And then ultimately we ended up with, the two mRNA drugs that we use for COVID, and that saved a lot of lives, right? Anyway, the whole point is trust, right? A lot of people are not trusting medicine within Somaliland, and the reason partially is because they do not sense that you're using evidence-based medicine. And the only way we can grow trust in the system and say, you cannot believe how many people I tell, you do not need to go to India for this problem. There are many physicians that can help you in Somaliland. Inta qof aan ku iraado war India tigina iyagoo lacag ururinayo 6,000 10,000 ururinayo halka u sii socdaan ku iraado uma baahnin inaad tagtaan halkan iska joogo khatiirta meesha jooga waxaan idinka caawin karay sida kaliya ee aynu ku develop garayn karayno trustka dadka masaakiinteed inoo wada baahan hooyooyinkeena ee dalka jooga waxa weeye in aynu isticmaalno evidence-based medicine. And before you are able to even generate any research at the level of the university in Borama, in Hargeisa, in Burco, in Lasanod, in anywhere within the country, before you can do that, you have to start with using the evidence that's already available and practicing it. And that is also, as Muslims, that's a very important thing, right? You cannot do harm to people. And so you have to really pay attention to that, because these things can cause irreparable harm to patients if you do not take into account how the evidence has been generated. Okay, I'll stop here. I don't know if I have any time for questions. Hello?
Thank you, Doctor. Thank you for the great presentation. Really appreciated really appreciated the depth of your insights, and thank you. And so I don't know how sorry.
Doctor, waan ku salaamayaa aad baan u mahadsantahay topic-kan wuxuu ahaa topic interesting leh sidoo kale gaab ku jiro markaad eegto bulshadeena iyo dhakhaatiirta laftarkoodaba waxaan filayaa inaad fahmaysaa af Soomaaliga si su-aasha ku weydiin lahaa waxay noqonaysaa haddii aynu fiirsano caada dhaqameedka amba dadkeena Soomaalidu leeyihiin mararka qaar way iskhilaafayaan inaad ethically iyo evidence based kiiba ku dhaqanto marka taasoo kala on your experience sidee baa la isku waafajin karaa marka labaadna waxaan ku weydiin lahaa su'aal la xiriira xagga researchka oo ah sidee loo heli karaa amba maxaa looga baahan yahay qof kastoo physician sababtoo ah dadkeena amba imka physicianada amba jaamacadaha ku jira waxay rabaan inay bal kor u qaadaan aqoontooda xirfadooda researchka marka maxaa looga baahan yahay qofka kor u qaadi kara xirfadiisa researchka su'aasheeda labaad researchka la xiriira amba saddexaadna waxay noqonaysaa maxay tahay amba topicyada ugu muhiimsan ee isleedahay maanta waxa u baahan in laga sameeyo Somaliland maxay noqon karaa si ay uga faa'iideystaan dadka kale aad baad maasantay
okay waa saddex su'aalood marka ma ka wada jawaabo saddexda kula okay ayo waa inaan qoro markaa hadda maskaxdayda saa uma fiicneen
واي كجواب
okay I can jawab okay the first one waxa weeyaan waxaad tidhi sideebaa qofka hadduu qof haddii culturekii aanu ku ogolayn inaad evidence based isticmaasho sideebaa arrimahaas magaraysaa looga hortegi karaa anigu waxay la tahay jawaabtaas way fududahay ko sababtay u fududahay waxa weeye bin aadamkan aad caawinayso dee ma raba inaan u bedelo lecture diiniya laakiin waxaa kaa saaran mas-uuliyad baa kaa saaran aakhirana waa lagu qabsanaya qofkaas marka cidna inaad kaga haybadaysato maaha haddii qofku ama ha noqdo qof kaa sarreeya ya aayaddii idinkaa dee qolyihiina qur-aanka iga xafidsan baan u malaynaya walow calaa aabaa'ikum bay ahayd soo maaha aayaddii يعني هدي الربا قسطك يو مجالس عدل جايين لقول رقمه ولو على أباك هدو أباها أنا نقول قف عدو دورها نقوله أنا وأرنت وحنا مرينا هالكاسي هوسي ما نفسه قفنا إنا مجالس كجا هاي بدي ستو معها إنا استعمال شو the best available evidence context قف كاس العاون يسامح شو يالو نعد كأكتو إن هدية لجو أما شغلة هلا جاي ريو أما هالنقطة مجالس عندنا كجا هاي بدي سبانو كورن كو laba research ka حاجة laga bilaabi karaa ama I don't remember the second question but the one other thing I will tell you waxa weeyaan meesha ugu horeysa aad ka bilaabayso research ba intaan ka fakirin qof evidence seeking ama tahay qof adigu mar kasta culture-kaaga caadadaada ma ka dhigatay waxaan u sheegayo qofka ama patient-ka حاجان ككان دكتور هبل بقى يقول لي واحد شقينا ما ultimately دكتور هبل لفتيسو ما دو كوشي يمشي وكسر حكتي وين هذا دوغنا سو اكتو ان ادبرتو at some point you will develop وما باهني وقت كلا garanaysa qofka bent wax iska sheegay qofka ma garanaysa laakiin you have to start using evidence and resources up to date ko kala wayna isticmaashaan all of you have access to up to date every condition has a treatment protocol. waxaanu ka hadalnay matalo kale ilmihi yaraa ee seizure-kii ugu horeeyay ku dhacay a child you know that has his first seizure activity whatever it is lama siin karo dawo lama siinayo dawo seizure so maaha that evidence should not be wax controversial inuu noqdo maaha ilmo yaroo kugu yimid temperature ama wax kasta risperidone inaad siiso waxa u baahan maaha abaal laakiin waxa ay u eg tahay dad badan oo dhakhaatiir oo practice gareynaya inaanay evidence-ka laba soconba so I don't know where they get their idea so intaana research aynaan ka fakerin research already la sameeyey evidence-ka adduunku isku raacay inaad isticmaasho inaad isbarto naftaada ku khasabto caadaysato taasaad ka bilaabaysaa the third element markaas the idea of research is really simple مشاكلك كوجو هريريسن إليك وليبا عافماتك كو تخصصا لا حريرة وأنا سؤال سويديس أوكي يعني واحد مشكلة الحقيقة إيمان يسألنا سويديس هذا دركتو ضد بدن أو مثلا كلا إن مثلا إمك هذا ما تكويديو si evidence ay ku base garaysan research ku base garaysan waa maxay waxa ugu badan ee qofka ED-ga Borama Regional Hospital uu u imaado haddaan ku weydiiyo waa in ay jirto meel aad waxa ka soo saari karto soma evidence waa inuu jiro evidence kaas markaa gathering waxa weeye wuxuu ka biloobaa inay su'aasha kugu dhalata aad intaad qiimayso aad dabeedna set garayn karto study in a procedural in a methodical way dena su'aasha jawaabteedii aad dooni karto marka waxaad ka bilaabaysaa researchka waxaad ka bilaabaysaa su'aasha saxda inaad isweydiin kartaa oo qofku su'aalaha ku soo noqnoqonaya sidee baan uga jawaabaa uu ku isku taxallujiyo researchka in badan way fail garowdaa laakiin the next element waxa weeye inaad you have to seek mentors. The only way research can be done is you need mentors to help guide you. Adiguna curiosity-ga iyo questions-ka keenaysa mentor-kuna wuxuu wadada saxda ah ku marinaya and then that's how you establish a research culture. Yeah, I'll leave it at that.
كل ما صنت دكتورة كل وقت كان هذا السؤال كله وحنا نسكت هنا إنه هب أونلاين كويدين كرنا مدام سشن كنا قبل ما هذا نسكت هنا وصدرنا دكتورة وحنا وصدرنا لينك كدينا بس بتسكن اللينك ما سينا ويجي كويش نسال كاسي قصة مريض إن شاء الله.
أردنا وحوي وإنه والحريري كنا وحنا سوين كنا more research and more lectures at Amoud University مركا and faculty iyo teamka hay la soo xiriiraan and then we can do more of a lecture series yeah when we have time. خير باي دير الشيء إن شاء الله. السلام عليكم.